Next, I would like to invite Dr. Saikumar sir, a wonderful mentor to all of us. And he's a past president of KSOS and medical superintendent at Giridhara Institute. He'll be talking about polar cataracts and associated PC rents. Over to you, sir.
Thank you, Vanashri, for having me in this course. The moment we hear about posterior polar cataract, your heart sinks. You are wondering what to do, whether you'll have a drop, whether you have to have a backup. So these are the things, the thoughts that go through your mind. So I have been given the topic of posterior polar with PCR. So I am showing only PCR videos, not the normal videos. But just a few points of introduction. Most of the posterior polars that we operate have an intact capsule to begin with. So either the capsule is so weak that it just happens, or one of your techniques during PPC is not right and you have induced a rent. That is what normally happens. The pre-existing PC rents, which we talk about a lot, in number, if you look at the total number of PPCs that we do, is actually not much. In fact, there are many who believe that pre-existing polar rents with fibrosed margins may have a slightly better chance of the PC not giving way compared to a normal PPC. Some PC runs are inevitable and some are due to small judgment errors that we make. So this is my first video. So as we know, one of the risk factors for having a rent during surgery is a large PPC. When you have about more than half of the capsule with large whorls of PPC, then you have a high chance. So size definitely does matter in these situations. So here I've stained the capsule. Whenever you do a PPC, try to do a good rhexis, adequate sized rhexis, because whatever happens, you have the sulcus there to fit in your intraocular lens. So I've gone in through just like my routine phaco, but here I had this ominous feeling that this is, I'm going to break this capsule. This is a very hard cataract, so I tried to make a crack and there it goes. So there you have the rent there. I am trying to retrieve at least one part of it so that my VR surgeon has less job to do. But, the most of the thing has dropped down into the nucleus. Into the vitreous. So when you have this situation here, please don't meddle with the piece. I think this has been emphasized many times for all of you. But the moment it drops to the mid vitreous and you have this feeling that somehow I'll take it out, you'll end up in a lot of trouble. So make sure that you call for help. So here I have my VR colleague who comes in and takes out all the pieces from there, triamcinolone, PVD, all that is happening, and then in goes the 3-piece lens, which is then captured with the optic is captured. So this patient actually does very well, and I actually have sutured the main wound as well. Now this was a small posterior polar cataract where initially I thought that I will easily get away with my routine PPC technique. My routine PPC technique is to do a very, very minimal hydrodelineation, probably almost nothing at all, just loosening up the area of the nucleus there. And then without any rotation, I chop small pieces and then mechanically move the nucleus into the center, into the phaco probe from various sides and finish it. But as I am finishing here, as I am doing my coaxial irrigation aspiration, I find that there is a PC run there. So this is the typical, like Dr. Sandhya showed, this is the typical PC run that you get in a PPC, a long linear PC run there. Till this point, there is no vitreous. So that is the importance, or something that I want to emphasize, is the chamber maintenance. The moment you see a rent, don't come out. Always remain there. There is a significant chance, I am not saying percentages, but there is a significant chance that you have an intact anterior hyaloid at the end of your surgery, and you can still get away by not doing a vitrectomy in these situations. So here, before you come out, always fill the chamber with a dispersive viscoelastic, and then again here a 3-piece lens goes in and is captured. There is no vitreous there. I have not done an anterior vitrectomy. There was a small piece of cortex remaining there. I went in with a Simcoe cannula with a very low irrigation and removed that piece of cortex once the intraocular lens was implanted. So maintaining chamber is extremely important in all posterior polar cataracts. This was a femto PPC where the nucleus was a bit white. So I asked my colleague who does femto not to do the lens fragmentation. So only rhexis was done here. So again, I thought that, the femto rhexis gives you a very ideal sized rhexis so that you can place the lens in the sulcus whenever you want to. This had a large epinucleus, hardly any nucleus. So I'm going in with my coaxial irrigation aspiration and slowly trying to maneuver out. And here again, I have this linear large PC rent. So again, chamber maintenance extremely important. There was some vitreous in the anterior chamber, small strands of vitreous. So I'm doing a limited vitrectomy. And like Minu told, in all these situations, always have a 3-piece lens backup. There are surgeons who you might have seen videos where you see that there is a linear rent, the rest of the capsule is normal. You can still go ahead and put in a single piece lens inside the bag. But if you have seen the rent, don't do that. This is my thought process and my advice. But if you have already put in the lens and then the capsule breaks and you feel that the lens is stable, don't touch that lens. Leave it there. So that is what I'm going to show you next. So which just to tell you that posterior polar capsules can give way at any point of time. So here again, routine posterior polar, my routine technique, I have put in the intraocular lens here. The lens goes into the bag. Till that point, the capsule is intact. And there was a small epinuclear, remnant at one of the paracentesis, and go in with my coaxial irrigation aspiration to remove that. And suddenly I noticed that there is a PC rent there. So this is even at any point of time, you can see the rent there. This is the linear PC rent that you can see even after the implantation. But if you have the lens being stable inside the bag, the haptics are oriented in a way that the lens is not moving. I have not seen a reverse rupture so far. We talk about wraparound tears where you have a rhexis cut and the rhexis cut goes behind. But so far, technically it can happen. You can have a PPC with a split capsule. It can come into the anterior capsular margin and break the rhexis margin as well. I haven't seen it so far. I don't know whether it's a described entity called a reverse wraparound tear. And finally, in Malayalam we say Varanulladu vazhi thangula. And in English we can say what has to happen will happen. So this was a posterior polar cataract where again I did everything well. The nucleus fragmentation goes on just like my routine technique, and I slowly break open the pieces, and without any rotation using the Sinski hook, I slowly manipulate the pieces into the phaco probe. And I'm done here. I'm going to inject Cohevisc inside the eye and the cannula slips. Okay, the cannula slips goes deep into the vitreous. So my scrub nurse has given me a non-lure locking syringe with a cannula, and I also, because you have to do it single-handedly. Your right hand is in with a coaxial irrigation, so you have to use a one-handed technique. So there it slips, and I got a heart attack when I took out the cannula. It was not when it went in. When I took out, I was wondering, oh my God, this must have gone and hit the retina somewhere. So that much deep it went inside, but luckily it has stopped short of the retina, and so you have to do there was significant amount of vitreous there. So I did anterior vitrectomy, and like in any posterior polar cataracts, it's a protocol in our institution. We always have backup 3-piece lenses, and so again 3-piece lens goes into the sulcus with a capture. So in summary, always be prepared, whether it is a VR backup, whether it is an anterior vitrectomy, whether it is a 3-piece IOL, always have a backup. Get an informed consent from all your posterior polar patients. Even if you think it is a configuration, it is not a typical posterior polar, I can get away with this PC may not break. It's always safer to inform the patient that you have a capsule which is likely to give you problems, and get an informed consent. Either do a peribulbar if that is the practice in your institute, or you go in and if necessary give a subtenance block, which is very, very simple, very, very effective. A good rhexis is extremely important. Don't make the rhexis very large, don't make it very small, ideal for a sulcus fixation with a capture. Careful with the hydro, either no hydro technique or minimal hydro technique. A gentle nucleotomy. Don't pull the nucleus too much from this side or that side, because that maneuver or even that cracking maneuver can cause a PC rent. Always, always maintain the anterior chamber. This is one thing that always has to be in mind. It is something that we have to practice in every phaco, in fact, not only in PPCs, but especially so in posterior polar cataracts. Never let the chamber shallow. The moment the chamber shallows, the thin capsule just gives way. So always remember that. And even the last wound hydration, don't take off your vigil from the eye. Normally once we put in the intraocular lens, we are sort of, okay, lens has gone in, now nothing is there to happen. So even the wound hydration, you have to be very, very careful and make sure you don't hydrate the wound or make the chamber very, very tight. So these are some PPC with PC rent experiences I thought I'll share with you. Thank you for your kind attention.
Thank you so much, sir, for the wonderful insights on posterior polar and PC